I'm really delighted to be here. I will say, as I always do in the beginning of talk about trauma and about violence, that these are hard topics to talk about, right? There are no topics that are more traumatic for human beings than thinking of being hurt by others. And so I definitely welcome if people want to get up and take a break, that's fine. And what I'm going to model for you is I'm going to give you a talk that I do give to healthcare providers so that they can understand how to take care of patients who are experiencing a really high burden of trauma. But these concepts that I'm going to discuss, I think, could apply to a family member, a friend, a neighbor, or patients that you serve in any capacity, or if you're doing research, could also apply to participants in your study. And what I'm going to model for you is something that I didn't do at the beginning of my career, and then realized that talking about violence and trauma, we really need to focus on taking care of ourselves when we're addressing violence and trauma, not just to maintain our own hopefulness and our own resilience, but actually to be healers, to be able to be healing for another human being. It's really helpful for us to stay grounded and us to stay rooted in compassion and hopefulness when somebody might be at a very low point. So I'm going to actually lead us in a small guided meditation, and then I'm going to remind us that even when I show even just an upsetting slide, that I will remodel for myself and for you how I stay grounded when I'm doing work with patients who have such a high burden of trauma. So I have nothing to disclose except for gratitude to my patients, my teachers like Margaret, my colleagues as well. So tonight I hope to define trauma and resilience. I'm going to discuss how trauma in childhood, so in early childhood, actually results in poor outcomes, poor health outcomes decades later after the trauma has occurred. I'm going to define trauma-informed care and describe ways of addressing trauma in healthcare. And then, as I said earlier, I'm going to emphasize that no matter what role you have in society, when you're addressing trauma or violence with others, taking care of yourself is really important while you're also trying to care for someone else. So take a moment, and if you'd like to close your eyes or just look down towards the ground, and take a moment and feel your weight sinking deeply into the chair. And then put your feet firmly on the ground and feel your feet growing roots into the earth. Roots deep into the earth that are tying you to the healing energy of the earth. And I'd like you to envision and even embody the energy of a tree. So as you breathe in, you can breathe in that healing energy through your roots. And as you breathe out, you can relax and feel a sense of peace. As you breathe in, even if you breathe in carbon dioxide as a tree would, you can, through your breath, transform that carbon dioxide to life-giving oxygen. And as you breathe in that healing energy of the earth, and you breathe out a sense of peace, and you breathe in that healing energy through your roots, and you breathe out a sense of compassion, breath by breath, as we all together in this room remain as grounded as possible, even when we're addressing painful topics together, we can form a healing and peaceful forest that serves to be a healing environment for all of us. So you can gently open your eyes. And as we go through this talk, I'm going to invite you to whenever you feel triggered or nervous or notice your heart rate increasing by any of the concepts we're discussing, to really feel your weight sinking into the healing energy of the earth. So the Substance Abuse and Mental Health Services Administration defines trauma as an event, a series of events, or set of circumstances like abuse or like other forms of violence, like community violence, that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects. I do not walk around keeping this definition in my head, actually at all times. What I think of, what for me, trauma, I think of crystallizes, is that trauma ruptures relationships. So I think if you remember that trauma ruptures relationships, that's a really helpful concept. So people who've experienced trauma may even feel a ruptured relationship with one's sense of self, where one feels alienated from one's own body or one's own thoughts or experiences. And trauma ruptures relationships between people as well. One model that I don't know if you've discussed during this series of lectures is the socio-ecological model. And that model looks at all of the levels in society in which there may be individual, family, community, or societal risk factors or protective factors for some type of adversity. We may experience trauma and adversity on the individual level, but also within the context of the family, the community, and as we're seeing, I think, played out on our national news every day, within society as well. And what's really important, especially for this course on vulnerable populations, is to think about the ways in which our policies actually specifically design our society such that some communities that are more vulnerable or under-resourced actually by design, by policy, experience a much higher burden of trauma and adversity than privileged communities. So trauma and adversity are actually really powerful social determinants of health, and they're not distributed equitably in society. So how common is trauma? Trauma is really a hidden epidemic that we don't talk about very much, but is far more common than anyone realizes. So even amongst a representative sample of residents of the United States who have an internet connection, over 90% of people said that they had experienced a very serious traumatic event in their lives. The sad fact is that children are exposed to a lot more trauma and adversity and violence than we realize. So children, for example, just in the course of 1 year, 60% of children have been exposed to at least one form of violence. And sadly, 10% have been exposed to actually 6 or more forms of violence in the year. So this is really hidden under the surface. It's not something we talk about a lot of the time, but most people have experienced trauma in their lives. And I know that during the substance use talk, the ACE study came up, but I'm going to go into that a little bit more just so that people understand how important this public health study is. It's amazing how much time it takes important studies to filter into our consciousness and our work. So this study was actually published in 1998 and is just now, in the past 5 years or so, getting appropriate attention for how important it is. But to describe it a bit, it was done at Kaiser San Diego. And what they had at that Kaiser was they had an intake center where people would fill out really exhaustive questionnaires about their experiences in life and all of their health risk factors. And then they would have physical exams and get put into various different preventive health types of groups to work on their health problems. It was a really large study done on 17,000 patients. And as part of this really exhaustive survey about people's experiences, they had 10 categories of childhood abuse, neglect, and household dysfunction. Those were things like being physically abused, sexually abused, emotionally abused, having a parent or other person in the household that was substance addicted, or had been incarcerated, or had a serious mental illness. And what they found was that in this quite privileged population, because most of the patients in this study were actually white, college-educated, and insured patients, the prevalence of adversity in childhood was shocking. No one had expected that, especially in a privileged population, the prevalence of adversity would be so high. And then what was more surprising to the researchers that they found was that the dose or the burden of adversity in childhood marched out in a dose-response relationship with every health outcome that they started to study. So if they looked at liver disease or lung disease or heart disease, your dose of adversity that you had experienced in childhood actually increased in a dose-response relationship to those poor health outcomes. So I'll just give you a little quiz. I won't ask you to call this out, but to just in your head, again, think of this population. It's a white, college-educated, and insured population, and what you think the prevalence of physical abuse or sexual abuse was in this population. And really sadly, if you guessed 3, that is actually correct. So 28% physical abuse and 20% sexual abuse, right? This is not something that is, now actually is being talked about a little bit more, actually, and is in our national news, but has not been talked about traditionally in society very much at all. And if we look, this is a kind of busy slide, but 2/3 of these patients actually had at least one ACE. And when you think of what counts as an ACE, even if you were hurt physically every single day of your childhood, that still counts as a 1 in this study. That counts as 1 for physical abuse. So this study dramatically underestimates the burden of adversity and the burden of abuse in childhood. But at least 2/3 of people had at least one experience that was quite severe adversity. And then 12.5% actually had 4 or more ACEs, which when we think of these categories is pretty shocking, that in this population there were 4 or more ACEs in 12.5%. What kinds of health outcomes now have been studied? I said this was first published in 1998. And there have been study after study after study published looking at how does adversity in childhood actually result in poor outcomes over the entire life course, right? Because obviously adversity in childhood also affects childhood, but the shocking thing about this study was that 20, 30, 40 years later, people's health had been affected by the adversity that they had had decades earlier. So we see a lot of adverse behaviors increasing, again, in a dose-response relationship with adversity in childhood, but then also adverse health outcomes like I was discussing with the liver disease, the heart disease, the lung disease. Some of these risk factors are astronomically higher than traditional risk factors that we talk about when we talk about risk factors increasing the risk of a particular disease. Most traditional risk factors we talk about double or triple the risk of a particular disease outcome. But for example, for suicide attempts, adults who have had 6 or more ACEs in childhood actually have 30 times the risk of a suicide attempt. And adolescents who have had 6 or more adversities in childhood have 51 times the risk of a suicide attempt later. So these are really powerful risk factors. And then the question to all the researchers was, how is this happening? How is it happening that things that affected people early in childhood are affecting their health decades later? And so for decades, we've had this debate going on in science, right, about nature versus nurture, our genes versus our environment. And what we now know is that that type of paradigm is not accurate. And what's happening is that nature and nurture are in a constant interplay and influencing one another. And so it is actually our experiences and our relationships that build our brains, build our bodies, and build our behavior. So if, for example, you look at the picture with this beautiful picture of this father or uncle cradling this baby and having a really attuned and really thoughtful, peaceful, loving, attuned relationship with this baby, that type of interaction really builds biology and brains and behavior in an optimal fashion, really builds our health optimally. If instead children are exposed to toxic stress, and by toxic stress what we mean is stress that is so overwhelming that it feels completely unmanageable to a child, and it's not buffered by a safe, stable, nurturing caregiver. So if instead a child is exposed to toxic stress, that can really alter the way that our brains and our bodies and our behavior are built. And what we now know is that toxic stress affects many different systems in our bodies. So it affects our neurologic development. It affects our neuroendocrine development, so the hormonal systems that begin in our brain and end in our adrenal glands, our fight or flight type of hormones are affected by toxic stress. Our inflammatory systems are affected by toxic stress. And also, incredibly, our genes and our epigenetics, so the chemicals around genes that result in changing of their expression, are also affected by toxic stress. Not to give you a completely hopeless picture, what we now are also starting to find out is that in prospective studies, there was one done in England recently, even if a child had just one adult in their life that they said they could trust and confide in, so it didn't even measure how often they saw this adult or interacted with this adult, but you had someone in your life that you really trusted and could confide in. That actually mitigated the adversity of ACEs in childhood, such that the health outcomes were not as bad if you actually have someone in your life in that way. So again, safe, stable, nurturing relationships, even if you have one, that is very helpful in building optimal biology. You don't have to remember this, and we'll have the slides, but this is just to tell you that there's one simple paper you can read that goes over the biology of toxic stress, and that the Harvard Center for the Developing Child actually has a brilliant website with lots of little videos that are great for everyone, from children to physicians, to look at how our brains built in relationship to our experiences. How does toxic stress affect us? So the model that has emerged from the ACE study is that there is now adversity or adverse childhood experiences in childhood that affects how our brains and our bodies develop, which results in social, emotional, and cognitive impairments. As I think you discussed in the substance use lecture, that those brain changes actually lead to an increased risk of substance use in the future. So then all of those changes lead to the adoption of high-risk behaviors that lead to disease, disability, and social problems later in life, and unfortunately actually lead to early death. So this slide is really shocking, but if people have 6 or more ACEs on a population level, that lowers the life expectancy by 20 years. So it's really hard for me to think about this slide, and this is the point in this talk where I always need to re-ground myself and take a deep breath, because I can feel my heart rate increasing when I realize what a severe impact childhood adversity is having on people's lives and is having on the entire life course. So really the roots of premature death are often being laid in childhood. And that's just childhood violence. Unfortunately, we know that people may experience quite a bit of violence in their adult lives as well. And just like those experiences affect our biology in childhood, they also affect our biology in adulthood. So IPV stands for intimate partner violence or interpersonal violence. And what we now know is, besides the obvious things like injuries, interpersonal violence is also associated with worse asthma or strokes or heart disease, because it is causing these biological changes. And then to really pile on thinking about, what devastating problem trauma is in our society, the ACE study, as I explained it, was really just dealing with household dysfunction and household adversity, and it was completely decontextualized from the way we live our lives, right? We live our lives in communities and in society that are filled with many forms of structural violence. And there's really a continuum between interpersonal violence and structural violence. I really think I've tried to think of all the different forms of trauma in life and how they are perpetuated and how they occur. And I've come to the conclusion that aside from car accidents, pretty much every form of trauma that we experience is rooted in oppression and discrimination. So for me, my work has really, my social justice work and my physician work has really come together in understanding that trauma is really rooted in oppression and discrimination, and that people in life are experiencing, as we said in that socio-ecological model, are experiencing adverse power dynamics, right, and abusive power dynamics at every level, from the individual level to the structural level. And when we look at some of these problems and we start to look at the biology of these problems, we're finding that the biology, for example, of racism has many of the same biological effects on our health as does interpersonal or family adversity during childhood. So the way I like to think of it, again, I said, it's trauma sort of ruptures relationships is the way I crystallize trauma, and it's rooted in oppression and discrimination. I also like to think of it as contagious. And how is it passed on? It's really passed on, as I said, on all these levels, from individuals to families, communities, and systems. It's passed on intergenerationally, and there's fascinating biology as well as behavior as to how that happens. But the mechanism through which it's passed on is really passed on through abusive power dynamics and discrimination. And then when we are helping somebody who is experiencing violence, or we hear a story that's really traumatic, it's passed on to us. I actually have many patients that are coming now to the healthcare setting unable to sleep and experiencing many of the symptoms of a traumatic experience just from watching the news, right? So trauma is passed on to us very easily, vicariously, when we see an upsetting a story in which someone else or a group of people is being treated badly. That actually affects us as well. So to turn to the more hopeful, the experience of trauma really can be mitigated by resilience. And resilience is the ability of an individual, a family, or a community to cope with adversity and trauma and adapt to challenges or change. And just as I said that trauma ruptures relationships, I like to think of resilience as a relational quality. We saw in that beautiful interaction between, father and baby that resilience was actually being built through that relationship. And so I think of resilience as a really healthy social connectedness. And that really means that whenever any of us, in whatever roles we're playing in society, can promote healthy, respectful, really strong, connected relationships to one another, that is very healing for people who've experienced trauma, which is most of us. We know now from resiliency research that if people have really low burdens of trauma in their life, their individual qualities of resilience, their sense of agency, their intelligence, their ability to adapt to problems, really is often enough to get through their traumatic circumstances. But if people are experiencing a really high burden of trauma, with trauma occurring at the individual, family, community, societal level, it really requires a multi-system and a multi-sector response to promote resilience in that case. So knowing all this and knowing about the ACE study, then a lot of us in healthcare started to think, what does this mean for patient care? What does this mean for us when we're taking care of patients? And you may hear people talking about trauma-informed care. And frankly, trauma-informed care has not yet been well studied. So this is very cutting edge. No one has actually built what they consider a trauma-informed care system in a healthcare system and then fully tested it to see if that actually changes health outcomes or not. So we are really actually at the forefront of making up what is trauma-informed care and what, based on our knowledge of trauma, what do we think it should be? And so again, SAMHSA, the Substance Abuse and Mental Health Services Administration, has done a lot of work in this regard. And they say that trauma-informed care should be a strength-based model. It should certainly be grounded in you understanding and responding to the impact of trauma. So you should really understand how trauma occurs and how it affects people. And then it should emphasize the physical, psychological, and emotional safety for everyone, for the providers and the survivors of trauma. And most importantly, create an opportunity for people to rebuild their lives. So that's how they define trauma-informed care. We are so lucky to be living in San Francisco as we try to figure out models of trauma-informed care, because our Department of Public Health here has committed to training all 9,000 Department of Public Health workers in what a trauma-informed system is. And what I love about their work is that they've talked about the healthcare system as an entire ecosystem. And really, the more I get deeply into trauma-informed care, the less I make any distinction between the employees of an organization and the patients, because we're all inhabiting that ecosystem together. And as we saw when we did that group meditation, how calm the room came together, and as we see when something upsetting happens, how easily it is for us all to escalate. It's really important that we treat the whole healthcare system as an ecosystem and try and create a healing space for everyone in it. So they've adopted these principles, which are really beautiful, and I do actually keep these in mind. I think they're great to keep in mind for life. I keep them in mind as I practice. And if you haven't learned about cultural humility, I just really encourage you to Google that and look up cultural humility and watch the fabulous video about this concept, because it's more than it sounds like. It's not just being humble about people's identity, but it's actually paying attention to what aspects of your identity hold a lot of privilege, and then what types of power dynamics are occurring between you and others, especially as a healthcare provider, and how to mitigate those power differentials. And then it has a social justice component as to like how can we make our healthcare institutions be accountable to the community as well. So I work with medical students, And they kept asking me, yeah, but I don't know what you're asking me to do when you're saying I should be practicing trauma-informed care. So I decided to come up with sort of a way that encapsulated what it is I'm doing when I feel like I'm providing trauma-informed care. And this is kind of the Sesame Street moment of my talk. The 4 C's is what I came up with, and I then ran it by a world-famous PTSD researcher, post-traumatic stress disorder researcher, to ask if these really were accurate in terms of trauma-informed care, and she agreed. Calm, contain, care, and cope. I keep in mind as I'm practicing, and I'm going to show you how I do that here. So Ms. Jones is a 44-year-old woman. She's coming to her first primary care visit complaining of pain and insomnia. She has diabetes and asthma. Both are very poorly controlled. So she's seen really frequently in the emergency department for pain and shortness of breath, and she's been noted to smell strongly of alcohol. And she is incredibly upset that I am late for the appointment. I will say that being late to an appointment, which I'm sure many of you have experienced, a provider being late to an appointment, is not a trauma-informed practice. If you have been raised in an atmosphere in which people were unreliable at best or actually abusive at worst, promising that you will be somewhere at a particular point in time and then not being there is really actually in and of itself triggering. And the whole healthcare environment is triggering, right? Like we have people in closed doors. They may have been locked in some places as a child or as an adult that they're not comfortable with. We have people get undressed before they even meet somebody. We don't explain things carefully enough. So the healthcare environment is a very triggering environment, and she's already upset before I've even walked into the door. So the first thing I'm doing before I open that door is I'm putting my hand on the door and I'm saying to myself, I need to calm myself. I need to take a deep breath. I need to really feel my feet rooting into the ground. And what I'm going to do is I'm going to use my body and I'm going to use my breath to co-regulate a sense of calmness with the patient so that if she's in a really heightened state of being triggered by this healthcare environment or her experiences, my body and my breath will help her feel more calm. I'm going to tell you, I would only be able to guess something like this before I walked in the room, but I wouldn't know this from her medical record. I'm going to tell you her hidden childhood story, which is very disturbing. But not atypical. So Ms. Jones' father was incarcerated for domestic violence when she was 10. Her uncle moved in ostensibly to help out, but instead sexually abused her for 3 years. She began drinking when she was 10 years old and did very poorly in school. And then she was placed in a group home at 13 because her mother felt she was out of control and couldn't actually take care of her. As an adult, she's actually just fled a violent relationship that she had with a female partner 5 years ago. And in her childhood, she remembers a favorite aunt as the only person that she felt ever truly loved her. So with calm, I'm not just talking about keeping my body and my breath calm, but I'm actually talking about keeping myself calm in terms of what are my goals for this visit. So I'm assuming when someone comes into my clinic and they have so many poorly controlled medical problems, knowing the ACE study, I'm actually assuming that childhood adversity and trauma are probably the most likely cause of their poorly controlled disease processes. So I'm already expecting that that's a possibility. And if that is a possibility and someone's brain and behavior has been modeled since childhood, then change is going to be slow. I actually know, because I took a complete career change in my 50s, that you can remodel your brain and your behavior even much later in life, and that this is possible to do. But it's not something that happens really quickly, right? It's something that happens slowly. So I have different goals as a physician because of trauma-informed care, when I walk into that room, I'm thinking that the most important things I'm going to do is I'm going to model a respectful and healthy relationship. I'm going to try and be as dependable as possible. I'm going to destigmatize her adverse coping behaviors like the alcohol use, right? Because it's rooted in these childhood experiences and she may not actually be aware of that connection. I'm going to focus a lot on resiliency, and I'm going to really pay very, very close attention to the power dynamics in that relationship, because if she has had any abusive power dynamics in her life, she may be very highly attuned to me having sort of a sense of power in the relationship as well. So to move on to our second C, contain, is that it's really important to talk about and introduce trauma in a way that allows a patient to feel emotional and physical safety, offers choice and control, and respects the time frame, right? Like if someone's experienced trauma and they go to an hour-long therapy visit, that's a really different context than a 15-minute primary care visit. The time frames are different, our roles are different. And then most importantly, I'm going to figure out ways to help people get connected to resources that might help them heal without them having to jump through the hoop of telling me their entire trauma story, right? Like, one shouldn't need to do that to be able to get help. And what I'm thinking with contain is I'm thinking also, how can this person feel more contained when they leave, right? How can they leave? They come in feeling triggered. How can they feel calm and contained and sort of put together when they leave? So one of the best ways to talk about violence and trauma in the context of a healthcare interaction, and I would say actually in the context of any interaction, even with neighbors or friends or others, is really to provide a little bit of education. For us, we provide education that's specific to the patient's health problems. I then, though, always explicitly mention the possibility of violence or trauma, because if you don't, I mean, a lot of people want to use the question, you know, does the patient feel safe at home? And people start thinking about asbestos or all sorts of other things that might be making them feel like their home isn't safe. So I think we need to be explicit about what we are talking about. But again, offering that assistance and intervention without requiring someone to really disclose their whole story. And where this approach of universal education was first tested was in this Planned Parenthood study, where they had the medical assistants outside the patient, when they're rooming the patient, say to the patient, you know, we know that sometimes your sexual partner could try and interfere with your birth control method. They could poke holes in condoms. They could throw out your pills. And so at our clinic here, we can offer you hidden methods of birth control. We can give you an IUD, an intrauterine device with the string cut really short. We can give you a depot shot that your partner won't be able to see. So if you want one of those types of birth control, ask for it. And people didn't have to say what was going on in their relationship. And even without saying it, reproductive coercion was dropped by 71%. So just providing people with this education and then some options is really helpful. So in healthcare settings, I will tell people, you know, our relationships actually affect our health. So for Ms. Jones, I talk to all patients with asthma that's really poorly controlled about how our relationships affect our health. And if your partner or somebody else is threatening you or putting you down or criticizing you or hurting you, that can cause a lot of stress and make your asthma much worse. So we have help available here for people who are being hurt by someone else, and we have an advocate we can call down to clinic. So if that's ever a problem, we do have help for you, and these are places you could get help. And then I personally, because I've been doing this so long, and I think when you're very non-judgmental, actually people for adulthood trauma feel fairly actually do disclose what's going on. I actually follow with direct questions to people about adulthood experiences. So has your partner or anyone else ever hit you, hurt you, threatened you, made you feel afraid? I do ask my patients these questions, and people do disclose what's going on. Lots of more questions if time permits. So Miss Jones, in this case, tells us that she fled a relationship 5 years ago where she was being hurt. And I will just say that in our clinics at San Francisco General, 15% of women have been hurt or threatened in the past 12 months in a study that was done in 2000, and 51% in lifetime. So again, this is really a hidden epidemic, but is occurring quite frequently. In terms of early trauma or trauma that might have occurred in childhood, thinking about when did someone start using substances, or when did someone first have a mental health complaint. It's unfortunately really common that I'll have patients that say that they don't remember a time that they weren't depressed. So I always ask, how old were you when you first started using alcohol? How old were you when you think you first became depressed? And if I get an answer of a young age, I really have my answer, right? Like if someone started drinking at age 10, I'm aware that they had something very difficult happening in childhood. I sometimes do, although I think this requires quite a lot more experience in talking to people, because childhood trauma is a very triggering topic. I do ask people about explain to them that how we were treated in childhood affects our health later in life. So I ask people who they grew up with and how did those people treat them. I will then try to make sure that the patient doesn't have to tell me more than they're ready to tell me, and I don't even think it's a great model for them if they were betrayed as a child to tell me too much. So I'll say, in my experience, when someone tells me they began drinking at age 10, it's often because they were experiencing very difficult things in childhood. And since we're just meeting each other for the first time today, I don't need you to go into all those details, but I'm happy to refer you to a counselor or a therapist if you would like. So again, offering those options. And what we find is that some people who have gotten a lot of help before for trauma will just tell you that, thank you, I was in years of therapy, I'm doing fine now, and I then thank people for being so brave as to share with me. I think if you're at a loss for words when people tell you that something terrible has happened to them in childhood, asking people how they feel the experience has affected them, but also then saying, I'm so sorry that happened to you. I mean, we see here playing out in the news now every day with Me Too, right? How important it is that people be believed when they describe their experiences. So just saying, I'm really sorry that happened to you, expresses your empathy for that situation, as well as your belief that that person experienced that trauma. If instead people become very upset, I then start doing the meditation again with people to help them calm down. So to get to the last two C's, care and cope, it's really, this is what SAMHSA actually says is sort of the key to trauma-informed care, is that people would make that link between their childhood experiences and their adulthood adverse coping behaviors, and stop feeling quite as guilty about behaviors that actually are rooted in childhood adversity. So really emphasizing good self-care and compassion for the patient. And the paradigm shift is thinking about not what's wrong with people, but instead what has happened to people that have led to these circumstances. So really understanding that when people have been hurt, ironically, they feel very guilty and ashamed of being hurt, and trying to be non-judgmental and make that connection that, oh, this makes perfect sense because of how you were treated. People have very complicated feelings towards people who have hurt them. So people may often feel a lot of love as well as hate at the same time, or hope and anger at the same time. So I'm really careful to not be judgmental about people's feelings and to tell people that ambivalent feelings or conflicting feelings are the norm. Like that is a normal experience when you've been hurt by somebody that you loved or were in a close relationship with. So I might say to Ms. Jones, no wonder you started drinking when you were 10 years old. It was a way for you to cope with an impossible and painful situation. And that is often a big aha for patients who have been beating themselves up and feeling really guilty over their substance use. And then telling people, that we all deserve to be treated well, and again saying, I'm sorry those things happened. And then the key is, how do we help people rebuild? How do we emphasize those skills, those behaviors, those interventions that build upon their own strengths, their resiliency, their social connectedness? I certainly tell people directly, like, wow, you have survived incredibly difficult circumstances. I'm actually careful not to praise, instead to sort of affirm what's happened, because, again, when people are sensitive to judgment, I think even praise is sort of the flip side of criticism. So that's a more subtle distinction, but I am really much more likely to use like affirmation, like, you have survived this. I definitely tell people I'm really happy that they reached out for support. And then I'm trying to remind people of all of the types of circumstances that make them feel stronger. So really focusing on what it felt to be loved by that aunt, and that she was really important to your life, because that reminds her of a time she felt worthy as a child. And then even when the fastest way to figure out how people cope as a physician is just saying simply, when you're stressed, how do you cope? And then we really get into pretty deeply discussing the benefits of adverse coping techniques. And again, that's kind of a surprise often to patients, that I want to know what you really love about alcohol. I want to know how it makes you feel better. What does it do for you, right? Because eventually we're trying to take what alcohol or some substance does to make you feel more calm from your trauma, and we're trying to find other skills and other coping strategies that will work instead of those. I know that Dr. Schillinger shared with you his love for mnemonics, and this is one he developed on resiliencies. And again, this is now a different model, right? Like medical care is usually looking at problems and making a problem list. I've started making solutions and coping lists for my patients, and asking them very deeply about how do they cope and what do they do that makes them feel better. So for a patient who had very severe post-traumatic stress disorder, a few months ago, I was talking with him about music as a coping strategy. And he listens to all types of different music. But I was like, no, let's talk really carefully about what how does classical music make you feel? How does hip hop make you feel? How does R&B make you feel? And we hit upon R&B is the music that actually makes him feel less traumatized and more calm. And then, could you play R&B 5 times throughout the day and try to de-stress in that way? So you're really trying to find any types of coping skills that will help people. And then my final few slides is just that not many people want to get into therapy, unfortunately, and we don't have enough therapy available. But if people will do trauma-specific therapy, what most trauma-specific therapies are doing is focusing on how do you regulate your emotions, because that's very disrupted when you've had a lot of childhood trauma. Then how do you have healthy relationships with others, because your relationship models are very disrupted. And then eventually, if you can get to a space where you feel really solid and you're not experiencing very severe post-traumatic stress, how can you actually reframe this trauma narrative so you understand how you did survive it, rather than be destroyed or teared down by it? We certainly, and I hope that's been emphasized throughout this course, we need to actually address not just interpersonal violence on the individual level, but like actually on the structural level, right? Because people are experiencing a lot of trauma on all of those levels. So we need to try and address all of those things. And then I always, it's really hard for doctors to not take over and instead help empower someone and help them take those actions that will help them. I'm going to tell you that this website, which will be in the slides, is really helpful for families, friends, providers, has safety plans on it for people experiencing adulthood interpersonal violence, has a lot of good materials on it. I'm going to remind us after all of this to take a deep breath, and then for us to all always take care of ourselves while we're taking care of others. Yeah, so I'll leave that there and can take some questions. Right, so the question is, what would be different in the services that a medical provider or a psychologist might have in addressing trauma? And I think that first and foremost, that idea of paying attention to the context of the interaction, such that sometimes the patient will actually have a preference for what type of provider they feel it's less stigmatizing to talk to. So there may be some patients who feel that they don't want to tell anything private to a medical provider, and that would only be discussed with a psychologist. And then there may be some patients who feel like I'm too ashamed to go to a psychologist. That means you're saying I'm crazy. And then more will need to be done in helping the patient with the medical provider helping with the trauma. So one, the patient gets to decide who they want to talk with, but the context of the visits, we really don't have any longer. I started this work when we had a long time to spend with patients. We don't have as much time with the patient during our interactions now. And I think it's very important that, especially with childhood trauma, you don't elicit a very detailed trauma history in a short period of time where the person's going to feel really destabilized and not feel, once they leave the visit, they're going to feel like, wow, I can't come back because that was just too upsetting. So I think you have a longer period of time usually with a psychologist, and they have much more training and skills at working on trauma. So I think it's often most appropriate if the patient will see a psychologist to do that. That said, for all of us, for our psychologists and for our medical providers, we are teaching people a lot of these techniques to do like deep breathing with the patient and grounding exercises so that the patient feels like the interaction is healing and they gain these skills to use outside. And I've had patients who have had multiple hospitalizations and emergency room visits because of stress-related triggers to illnesses like migraines, for example. And with these breathing techniques and meditation techniques, we've plummeted the number of hospitalizations and emergency department visits. Other questions? Yeah? Right. This is a really beautiful question. I'll repeat it. Saying that healthcare providers of every type are taking care of people that have had a lot of violence and trauma, and that must obviously take a toll on the healthcare providers, and who is taking care of the healthcare providers. I personally did not pay enough attention to the toll that doing this work was taking on myself, and learned the hard way that your question is absolutely key and that we must take care of ourselves while we're doing this work. When I am talking about these grounding techniques and these breathing techniques, I actually really mean that I am going throughout my day. I have now worked on it for so many years, the last, sort of 5 to 7 years, that I am doing those grounding and breathing techniques in the moment while I am at work. And I'm finding that the more I can stay grounded and the more I can stay in a physiologically calm state and a compassionate state, the less sticky those trauma details are to my brain. So that helps. But I think your question also brings to bear, why is it that when you're training to be a therapist, you're required to do therapy yourself, right? And why is it that for nurses or medical students or physical therapy students or dentistry students who are also seeing a lot of trauma, why do we not have therapy incorporated into those healing professions as well? And I think that, we should be moving towards doing that more, because we are discussing really triggering and really painful, difficult topics. We're witnesses to very difficult experiences. Yeah. Right. So the question is, we have an audience member that works at the Osher Center, and at that center, a lot of mindfulness-based stress reduction techniques are taught. And what are the differences really between some of the trauma-informed, or what we would say is trauma-specific services, psychological services, and other mindfulness-based stress reduction techniques? There's a very famous trauma expert, Bessel van der Kolk, who actually discusses that much of post-traumatic stress disorder is a bodily experience, and that using mindfulness techniques, yoga, sometimes even expressive arts therapies like drama and other arts can be really helpful for people to heal. So I think the people who are most on the cutting edge of doing this type of work are experimenting with putting together techniques that help with your emotional and physiologic regulation at the same time. But you need to learn skills to regulate your affect, your emotions. And sometimes when you have such a high burden of trauma, that actually requires bodily, physiologic skills of regulation as well. So I think even at the Trauma Recovery Center, which is a model center for the country and the state on doing trauma-specific therapy, they incorporate a lot of mindfulness-based stress reduction techniques into their therapy. But ultimately, they're extremely skilled at helping people in a safe and controlled fashion rework their trauma narrative. That really can't be done until what they call the safety and stabilization phase is finished. So if people are not experiencing enough safety or stabilization, they're not really ready to reprocess a lot of the story. But I think the cutting edge people are putting a lot of that all together. Thank you. Thanks.